Hi, this is Dr. Ravali. What's your name?
My name is Kumar.
What's your age?
25.
Do you have any habit of drinking or smoking?
No,
Okay. Do you have past health history of pneumonia?
no.
Okay.
Inspection can already yield signs for pulmonary conditions such as barrel chest caused by emphysema. Additional diagnostic clues include an altered respiratory rate, an imbalance between inspiration and expiration, or signs of dyspnea, such as intercostal distractions or inaudible use of accessory muscles of respiratory. Now let's begin with the percussion of lungs. The examiner places one middle finger firmly on the patient's chest and strike it with the middle finger of the another hand. Physiologically, the air-filled pulmonary tissue should produce a resonant sound below the level of lungs. The examination usually starts cranially about a hand with laterally to spine and move caudally, alternating between both sides in the lower thoracic area. Percussion is also conducted from medial to lateral. Dullness to percussion can indicate effusion. For example, tumor in contrast, hypersense results from emphysema on pneumothorax. The mobility of lungs is best assessed by first determining the transition from resonant to dullness and complete exhalation, which correspond to the inferior border of deflated lungs. Percussion is then repeated on maximum inspiration to find the border where the lungs are inflated by distance between both borders determines pulmonary, respiratory, and mobility. Unilateral dullness to percussion should always compare to other side. To confirm the findings, effusion typically presents as dullness that rises from medial to lateral flex. Respiratory expansion of thorax can be checked by palpation. During expiration, the examiner presses both hands on lateral thorax and applies mild pressure to create skin folds. On inspiration, these folds should vanish bilaterally in case of impaired ventilation. For example, in pneumothorax, respiratory expansion can be asymmetric. Palpation is also used to access tactile parameters. If the patient is asked to say the word 99 in a deep voice, mild vibration should be felt in the lower lung segments around the level of 8th and 10th ribs. Increased tactile parameters, which indicates increased sound conduction, can be found for example pneumonia, whereas decreased parameters, therefore decreased condition, can result pleural effusion. Closely related to tactile parameters is bronchocephaly. The patient is asked to whisper 66 while the examiner oscillates the lungs. In states of increased sounds, the conduction whisper is louder. If the sound conduction is decreased, it is quieter or disappear completely. The most important test when examining lungs is oscillation. While the patient is breathing regularly and through the mouth, it follows same pattern as percussion. Oscillation allows evaluation of breath sounds which can be diminished or increased. For instance, further the ratio of inspiration to expiration time should be noted. Oscillation may also reveal other abnormal findings such as dry or wet crackles or pleural friction rub. Breath sounds heard over normal pulmonary tissue or vesicular. Oscillation across the upper always results in bronchial breath which have a higher pitch in comparison. Bronchial breath sounds heard over pulmonary tissue are considered pathological and hence evaluating the right middle lobe is best achieved through the anterior oscillation. Therefore, if pneumonia is suspected, the lungs should always be examined from anterior as well. Oscillation is not limited to the lungs but should also include the trachea, tracheal stenosis, produce inspiratory stridor, which can be best heard posteriorly in the paravestibular area around anterior above the sternum.